So let's get things kicked off. So tonight is our webinar on CeQur Simplicity, and we're going to be talking about removing known barriers to mealtime insulin dosing with CeQur Simplicity. And we're happy to announce that these are the first webinars since we've gotten our 4-day wear clearance from the FDA. We got that clearance earlier in this year, but we went live with that product out in the market in July of this year. So next slide, please. So these are the topics we're going to discuss today. We're going to first cover the unmet need in insulin delivery, and of course, how our product, CeQur Simplicity, addresses those unmet needs. We'll talk about the product's features and benefits, and then we'll cover clinical data, user satisfaction, real-world evidence, and I'm excited to say that we're going to also have a patient case study, as you all know, and excited for you all to see that case study, and then we'll summarize with some prescribing information, etc. So now I have the opportunity to introduce you all to our speakers, who you'll see in just a few seconds. First off, we have Jennifer Goldman. She is a clinical pharmacist, certified diabetes care and education specialist, board certified in advanced diabetes management, and is a fellow of the American College of Clinical Pharmacy. In addition, Jennifer is a director of cardiometabolic services at Well Life Medical, and she's going to make sure I say this correctly, Peabody, Massachusetts, not Peabody. And is a professor of pharmacy practice at Massachusetts College of Pharmacy and Health Sciences in Boston. In addition, we have David Soliman, who was a doctor of nursing practice, has a Master of Science in Nursing, is an advanced practice registered nurse, is a family nurse practitioner, board certified, and also is a certified diabetes care and education specialist, certified medical surgical registered nurse. And you can find David at Temecula Valley Endocrinology, and he is also a clinical associate professor at the University of San Diego. So tonight's program is sponsored by CeQur, and the speakers are speaking on behalf of our company, CeQur. I'm also excited to share with you our vision and mission for CeQur, and that is to simplify the lives of people with diabetes. And we do so with providing convenient, discreet, and injection-free dosing with our patch, CeQur Simplicity. So without further ado, I'd like to hand the keys over to Jennifer, and she'll get things kicked off. Thank you, Jennifer.
Thank you. Thanks, Chris. Thank you, everybody, for joining us tonight. And if you have any questions, please, we'll definitely have time to discuss them at the end. And I think that what's important to remember is that insulin that's not injected actually doesn't work. So why are patients not using their insulin? So we're going to address that. We'll look at a lot of the clinical data and really where does CeQur Simplicity fit. So I think a really good place to start is I'm going to have David talk about one of his patients. And this is a really interesting case, and especially how it progresses over time. So we'll come back to this case a little bit again at the end. But David, please take it away. Tell us about your patient.
Thank you, Jen. So this is my patient 2 years ago. I'm going to discuss a little bit of the details surrounding her diabetes care and how CeQur fit in and solve that barrier for her. So this is our 79-year-old female Hispanic patient with type 2 diabetes diagnosed in 1993. She is 131 pounds, 5 feet and 5 inches tall, BMI of 21.9. So when she initially got diagnosed, metformin was started for her, and she's using it to the present time. Unfortunately, her diabetes progressed and blood sugar went up, and it necessitated the insulin therapy. So she was initially started on Lantus or glargine insulin, and then her blood sugar just kept going higher progressively. She could not do multiple shots per day, so initially was started on V-Go, which is another insulin patch that offers both basal and bolus therapy. However, this became problematic because V-Go is set with fixed basal doses of either 20 units, 30 units, or 40 units per day, and she was having hypoglycemic episodes even at the lowest possible dose. So we switch her back to multi-dose injection, which is also glargine insulin and Humalog KwikPen. And this KwikPen was discontinued when we started CeQur Simplicity. We also started her on a continuous glucose monitor, the Freestyle Libre 2, which she uses until present. and of course, CeQur Simplicity, which is still being used at present. Her significant numbers to take note: that baseline, her A1C was 8.7%. Her time in range, based on the CGM monitor, was 24%, and her GMI, or predicted A1C, is 9.1%. She has been taught carb portioning, but continues to struggle with missed mealtime doses at that point. And this is a picture of her initial continuous glucose monitor reading before CeQur Simplicity. And I want you to focus on the left lower corner, in which her average blood sugar was 243 with a GMI, or the predicted A1C, of 9.1%, and her glucose variability of 35.6%, which tells us that her blood sugar is suffering from high fluctuations. On the right side, you will see the colorful chart. The green is the time in range, in which she's just staying at 24% of the time, and the rest of the time, either she's high or very high. The following slide shows us the graph, daily graph, and it can, you can see there that she has consistent after meal spikes, or what we call postprandial spikes. And it explains why her time in range is only 24%. The data shows and supports that the patient has not been getting her Humalog doses with every meal.
What you just brought up is she's skipping her insulin doses. And so that's certainly an issue. And we have actually millions of people on insulin. And I know that we were talking, David, what is the ADA update for how many?
The ADA update of the statistics for those who use insulin is actually up now to 8.4 million since 2022. And about half of that require mealtime insulin.
So we have 4 million people or so on mealtime insulin. And how many of them are like the patient you just described? So we certainly have many decades of support of the use of insulin. And it's one of the most effective ways to lower A1C, but it's not going to work if we're not using it. So even with the new drug classes, we still require, many patients require insulin use, and many still struggle, despite all of these new classes of drugs, to reach those targets. So oftentimes what we need is that intensification at mealtime dosing. And that's the one we're seeing so many people miss. So like your patient, 72% of people do not take their insulin outside of their home. So think about that for a second. Some of you I know are at a watch party, and some of you might be at your office or at home. But if you're out somewhere, think about it for yourself, and then imagine what it's like as your patients, and they have to have multiple daily injections and take it with them. So they're on an insulin pen. They have to bring it with them. Be at a restaurant. What are they going to do? They have to be at a meeting. Are they going to leave? Are they going to time it correctly? Is the food going to come out? So 72% don't take it. 57% report missing injections they know they should take. 53% forgot to dose. 40% forgot their insulin. 33% skipped on purpose. So certainly interfering with their daily activities. And think about diabetes distress. So patients being asked to inject this many times, and the distress that might cause them. And I want you to really kind of think about, when we're going through this, what if this was you? What if this was your family? So we do know that missing insulin doses raise A1C, so that's going to increase the risk of complications. So when you think about how many hours people actually spend in their day in the postprandial state, it's 12 hours. So if somebody is injecting 21 injections a week, so just three times a day with 3 meals, if they just miss 4 of them, that's it, 4 missed doses in that week, their A1C goes up by about 1%. So just 4 a week. So when you see patients, you say, over the last week, How many times you think you missed your dose? Oh, only 4 times. No big deal. It is a big deal. And we know what the data is from the UK PDS trial with every 1% decrease, 37% reduction in microvascular complications. We know that this is a problem. Every 1% increase, about a 22% increase in cardiovascular poor outcomes. So let's talk a little bit more about CeQur Simplicity. So it's an on-demand insulin delivery system. So it's subcutaneous bolus delivery. And I want you to remove from your thought process insulin pump. This is not to replace an insulin pump. This is for your patient using injections of insulin, whether it's syringes or pens. So this is instead of that. So on demand, it's been studied in adults over 21, not intended for pediatric patients, and it's labeled for Humalog U100 and Novolog U100. And it can be put on for 4 days. And I think you're going to understand, really the true value here when I show you some of this clinical data and I show you what it looks like. And Dave is going to show you when we get on screen with you, when himself holding it. So there's a need to simplify things and make things less burdensome for our patients. So CeQur Simplicity, it's convenient. It fits into their lives for mealtime dosing. It's wearable when they shower, when they exercise, when they're sleeping, swimming, 4 days. So up to 4 days to wear. It's designed to be easy, designed for ease of use. It's discreet. So you go to a meeting, you go to a watch party to watch a CeQur Simplicity webinar, and your CeQur is under your clothes. You're sitting right there in front of everyone, very discreet, right through your clothes. You can click, and we'll show you that in a second. So it's compact, less embarrassing. You don't need to go to the bathroom. You don't have to go wash your hands. You don't have to worry about where you're going to put the needle. Fewer injections. One device, up to 12 mealtime injections, 90 fewer injections per month, less pain. 90% of users reported mealtime insulin being painless with CeQur. 9 out of 10 claim that CeQur Simplicity helped them do a better job following their insulin regimen compared to using the syringe or the pen. So keep that in mind. This is what it looks like. It blown up, obviously, and the buttons on the side, which David will show you actually clicking them, is 2 units for every squeeze of that button. So someone needs to use 6 units, they're going to squeeze it 3 times. Small, flexible cannula for the insulin delivery. It's thin, so 4 stacked quarters thick. So we'll show you the side of it, and it's soft, it's comfortable, it's water resistant. It holds up to 200 units of insulin with a minimum fill of 100 units. It's, again, a bolus-only patch, so it complements using basal insulin. Or if you have patients that only require bolus insulin. So David, I like the way you talk about this slide. You have a very insightful thought process about this. So I'm going to have you talk about this slide.
So yeah, I think this is a very powerful image. Just looking at the 12 injections, it replaces for 4 days, whether it's 12 syringes or 12 pen needles. But behind this, each injection is actually 12 steps. And I'll enumerate them because that's my training as a certified diabetes care and education specialist. So when you get that pen or vial and syringe, you'll have to get it. If we stick to the pen, you're going to have to get the pen, put your needle on. You're going to have to prime it. You're going to have to dial the dose. You have to clean your skin, find appropriate spot, inject it, deliver the dose, and you have to hold that button for at least 10 seconds after it's delivered. You're going to remove it, and then you're going to remove the needle. You're going to put back the cap and then keep your pen, which 12 steps for 1 shot. So if you would look at this in a year, multiply this 1,095 shots by 12 is actually the number of steps you've simplified your patient's life.
And then you have to find somewhere to throw that needle away. And
Yes, I forgot
you're
that
a
step
nurse
already.
Exactly. So,
Sure.
so for, here, I think what I really want to have you take away from this is it's not an insulin pump. Again, not an insulin pump. It's really to take the place for those patients that are injecting. So it is individualized, flexible. You can have flexible basal dosing. We talked about, David presented his patient that had hypoglycemia when they were on fixed dosing on using the Vigo at that time, and she had hypoglycemia. So she had to come off it and went back on multiple daily injections because of that hypoglycemia. So you can have fixed bolus dosing using the CeQur, and they can adjust it based on their blood sugars, however the recommendations you give them, but their basal dose can be individualized. It's one up to 4 days. So every 4 days you can change it. It's discreet through the clothing, flexible cannula. So just to understand what the difference is. So let me show you a little bit of the clinical data and the user satisfaction data. So it's been well studied in more than 400 people, a lot of clinical evidence. We're not going to go through all of this evidence. I'm going to show you a randomized control trial, and we'll look at some real world data and try to really put this into perspective. So in this Bergenstahl study, and my good friend, one of the sugar queens, Davida Kruger, is one of the authors on this study as well. This was a multi-center randomized 1-to-1 pen versus patch crossover trial. So everyone got to use both. So half went on the pen, half went on the patch. At week 44, they crossed over for 4 weeks so that you were able to assess that patient outcomes. What did they think about it? How did they feel about it? These patients had type 2 diabetes. They were on basal only for at least 6 months before, and their A1Cs was 7.5 to 11%, so needed intensification. Their age was 22 to 75. And the other thing I want to point out that's not on the slide is the average BMI in this study was 32.5. So primary endpoint was change in A1C, and secondary endpoint efficacy, safety, patient-reported outcomes. When we look at the demographics and baseline characteristics, nothing ridiculous stands out other than, they all had diabetes 14, 15 years. So a good amount of time to increase to bolus insulin. The age above 58, 60. And we kind of talked about the weight, and their A1C, the mean was 8.6 and 8.7. So the summary here of this patient status, you can see 88% or so, 86% completed week 24 with the A1C, overall almost 87%, and 78%-ish completed to week 44. And so when you look at the crossover, 93% did the crossover. So that data is available. So when we see what happened, if you remember, so this is a clinical trial. So we know that patients in clinical trials try to follow the rules. And so what we're looking for in this is, are users of CeQur, is it as good as the gold standard? So non-inferiority. So the gold standard being injecting with mealtime insulin using a pen. And what you see here was, it was non-inferior. So non-inferiority was met. 1.7% decrease was seen at week 24. And 63% reached an A1C of less than 7, 85% less than 8 at week 24. And there was no differences in terms of hypoglycemia seen. So non-inferiority was met. Change from baseline at week 44 was 1.63%. And when we look at the time in range, so 70 to 180 time in range, we saw similar improvements. So again, non-inferiority from 48 to 74. A1C 8.5 to 6.8. So similar to what you were looking at with David's patient earlier, you're looking on the left, similar to that patient, not in range. So you can see the line brought down, time in range significantly improved from 48% to 74%.
Mhm.
After 24 weeks with CeQur, users increased their time in range by 50%. So that is very significant. We know that what we're looking for is a time in range of greater than 70% to target an A1C of less than 7.
Mhm.
In terms of adverse effects, very similar. So nothing really standing out. Again, we're looking at non-inferiority, severe hypoglycemic episodes, which is something we know when we add mealtime insulin to anyone with basal insulin, we're thinking about hypoglycemia. So not different, 2.2% in both arms. And interesting is, what about when they switched? How did the patients feel? How did the providers feel? And when you look at the subjects who were asked, their overall satisfaction was higher. Their satisfaction in terms of ease of use, 88% of the users said the CeQur Simplicity device helped them do a better job following their insulin regimen. The healthcare professionals also preferred the product to the pen. So in terms of advancing people from basal insulin to mealtime insulin, they were satisfied with CeQur, and they found that training their subjects was actually easy to do. So I think that's important. But remember when we talked about earlier, 72% of people miss their mealtime insulin injections. So that was a clinical trial when everyone's following the rules. What happens out in the real world? So yes, they can do it. Yes, CeQur was not inferior. What about real world experience? So this was a retrospective chart review, and four sensors were, the patients were accessed who are all on the CeQur Simplicity. 78 users were identified, so they had follow-up A1Cs. 65 were included for analysis because they had the pre and the post A1C. 10 had type 1 diabetes, and 55 of them had type 2 diabetes. 13 patients were actually excluded because there was something missing, either the pre or the post A1C was missing. The mean age was 59 plus or minus 13.9 years, and the mean duration of diabetes 20.6 years plus or minus 10. So thinking about the patient over time, it's now time to add mealtime insulin. So treatments before CeQur Simplicity was only 5 patients were on a basal only regimen. Multiple daily injections, 60 patients. So now these patients that were included, 60 of them were on basal bolus therapy, and their baseline A1C was 9.37 on basal bolus insulin, with the exception of 5 people who are on basal only. So 9.37. And CGM users, 34 patients use CGM. So before starting CeQur, 9.37 despite basal bolus, because we saw that data. We know what happens out in the real world. So what happened is those patients who started using CeQur reduced their A1C by 1.29%, with a 27% improvement in time in range. So even the real world experience, just taught, go out on your own, use the CeQur. This is what we saw. In terms of the CGM users, I'm a big proponent of CGM. And you can see here that those who actually use CGM had even more of an A1C reduction. So on the left, those using CGM, so another kind of plug to be able to recommend CGM for your patients with diabetes on insulin. And certainly if they're on CeQur, it's shown that it was improved. But it was improved even in the non-CGM users. But what did the patients think? What did they say? So on the left, what you see, this was a rating questionnaire. And insulin delivery method satisfaction, they preferred the Simplicity, CeQur. Interference with their activities, preferred CeQur. Clinical outcomes, preferred CeQur. Diabetes-related worry, preferred CeQur. And so think about that. That's always very important to patients, and that also goes hand in hand with psychological well-being. Also preferred with CeQur is that whole diabetes distress. 94% of patients were completely or very satisfied with Simplicity compared to 35% with their prior method, and 93% of patients said Simplicity is better than their previous method. So very high patient satisfaction. And again, imagine if this is you. So David, tell us what happened with your patient, and remind everybody, remind me too, what we see here with her.
All right. Thank you, Jen. And thank you for the discussion of that statistics and real RCTs and real world. So I feel like this case is actually grabbing one particular patient to see if it's the same experience from what we've seen in the studies. And I want to go back to the diabetes distress because this extends to the family, not just the patient, especially if the family is involved. And we will see this in our case. So just a review what I showed earlier. This is the blood sugar readings of the patient using the CGM before CeQur Simplicity. And so a couple of more information I wanted to add is that the patient actually did not tolerate any of the known other diabetes medications out there, and her C-peptide was actually low. And what that means is that her own insulin production is deficient, and although she's type 2, she's not producing her own insulin. We had challenges, as I mentioned, with Vigo, with hypoglycemia, because she needed less than the fixed 20 units that the Vigo was giving as a basal coverage. She depended on the family for the changes of the Vigo, which was required daily. So diabetes distress extended to the family. We have this caregiver burnout. It's like, their family have their own activities and priorities they need to do, and they try to accommodate what they need to do for their family. And if we can simplify that, that's one thing that I want to emphasize, is that for CeQur Simplicity, we're not intensifying their treatment, we're actually simplifying the steps for them so it's going to be doable. So that what we see in that randomized control studies, when they're actually taking the insulin, we will see the same results for our patients. So we switch her to the Humalog pens, but she would either forget to bring it with her, or she would forget the dose, or intentionally not take it because of her apprehension of the needles. The other barrier that I did not get to list here is some, aging-related dexterity issues, strength, that sometimes she has a hard time pressing the insulin pen, although we find it easy. It's different for each patient. So it resulted to inconsistent prandial boluses. I usually make this as an example. When you're insulin deficient, each carbohydrate that you take needs to be paid for by insulin. So what will happen if each time you eat, you had to go to the ATM, withdraw some money, go pay, and then the next snack, next meal, you do the same thing. You have to go to the ATM, get your cash, and then pay. So simplifying the insulin therapy is like setting up an auto pay, wherein you can just, instead of going through that 12 steps of preparing your insulin dose, you can just, touch the patch and then click it. So we ordered CeQur Simplicity on August of 2022, and she was started a month later after the family was trained and they got all their supplies. So they were very excited about this product that time, because the change of the patch is every 3 days and not every day. And they were able to scatter that responsibility across the people taking care of this patient, with more days apart. So this is 4 months after starting CeQur Simplicity. Notice the average blood sugar. It's now down to 188. 243 was the starting point, down to 188 after just slightly improving the consistency. And then the GMI, or your predicted A1C, is now down to 7.8%. And the time in range, which started at 24%, jumped up to 47%. So it nearly doubled within the first follow-up. And if you would see the time in range, as I've said, nearly doubled. The barrier here, or the barrier in this scenario, is that she was doing 1 click instead of the ordered 2 to 3 clicks with meals. So you would see that the postprandial spikes are still there. They're a little bit blunted, but they're still present. So we coach the family and the patient on the correct mealtime clicks. That's what we reinforced for this particular visit. So 8 months later, this will be the second follow-up. Look at the average blood sugar on the left lower side. It's 171. Our glucose management indicator is now down to 7.4%, and her time in range is 60%. So our goal time in range typically is between 70 to 80%. There's still some room for improvement, so we still have those very high readings. And the reason behind those, you would see that patient was doing the same amount of clicks regardless of the meals that she was eating. So we did a review of carb intake and tried to see the portions of the carbohydrate with meals and match it with an appropriate increased click. So I think breakfast was the higher amount that she's taking. So we added an extra click. Instead of 2 to 3, we made it 3 to 4 clicks before that meal. And we also added a correction click, which means that if her blood sugar before the meal is above 150, she adds an additional click to her mealtime dose. And this is 12 months later after that adjustment. If you would look at the blood sugar average of 154, now our predicted A1C, or GMI, is 7%. Our time in range is 79%, which is she's at goal. She has some high readings at 21%, but for us, this is already acceptable and on target. You would see that the glucose variability also went down from a 38% to a 21.6%. So the fluctuations have been addressed. So key takeaways, our time in range is now 79%, which is at goal. She didn't have any low blood sugars. And this particular slide shows us only 7 days because the patient ran out of sensors. And this is a side-by-side comparison of how the patient was doing before starting CeQur Simplicity and then 1 year later. So we met our glycemic targets by pairing those two, the CGM and our CeQur patch as part of the therapy. So in summary, A1C lowered from 8.7 to 7.3, which is a 1.4% decrease, which is consistent with the studies that Jen has discussed earlier. Time in range improved from 24% to 79%. And there was also an improvement with blood pressure. Although CeQur is not ordered for blood pressure, we know that when you improve blood sugar levels, it actually improves circulation. It lessens the viscosity of the blood. Blood flow is better when blood sugar is at target. So we obtained the freestyle as part of our strategy. And I think Jen also mentioned that in that study, that those who actually use the CGM technology with the CeQur Simplicity patch actually had better improvement with the A1C levels. We also, as part of our problem solving, we titrated clicks, and it was so much simpler to adjust clicks versus providing them that intimidating correction scale, right, that they face with the pens. So we adjusted mealtime, snacks, dosing, and a correction click. So we preferred CeQur Simplicity versus V-Go because we can titrate the basal insulin. We can adjust the long-acting insulin depending on the patient need, and we were not stuck to a very high basal coverage. And patient and family were very happy, again, because of that the burden was lifted from them. Instead of having to do a daily change or worrying about the patient doing or not doing the shots, we were able to alleviate that part of that caregiver, a factor for the caregiver burnout. So family involvement was really key to this in getting to her to use the patch correctly and efficiently. So it worked better for family schedule because it's an every 3-day change that time. And now it's even better because it's every 4 days. You're muted, Jen.
I bet they were thrilled with that.
You would see their anxiety lifted, like
Yeah, for sure.
lesser frown lines whenever they accompany the patient for their visit.
It reminds me of when probably it had to be at least 15 or more years ago that I had a patient that lived in an assisted living facility, and nurses there don't do medications. It's up to the family, and they had to go every day, every single day, and do the insulin injection. So something like this, every time I talk about CeQur, I sort of think about that patient and that family. And I recently saw a really lovely lady who 78 years old as well, and she actually was doing okay when we added mealtime insulin to her. So better than just basal alone. She couldn't take SGLT2 or GLP-1 receptor agonist. But when we looked at her CGM, and without CGM, you wouldn't see this. You could see, we saw the improvement, but there were days that she's obviously missing that dinner time.
Mhm.
So what's spectacular with the CGM is I can actually pinpoint the day we started CeQur, because from that day forward, you can see the difference in the CGM. So it's really amazing to see, and I think it's very rewarding for patients to see, especially when they can look at their own data and say, wow, this is really, made it easier for me, made it better for me, and I'm doing a better job now, and gives us an opportunity to say great work, that this is amazing.
One of the habits that this patient also had when she was on the pen still, when she was trying to do the injections by herself, if she does remember to do it, sometimes she intentionally lessens the dose because she's afraid of dropping. So with CeQur, she would, if she decided to do 2 clicks instead of 4, and she sees the blood sugar go up after meal, she can actually do the post-meal clicks to kind of, catch up
Yep.
with the blood sugar, because it's not another shot that she has to struggle with.
That's an excellent point. Excellent point. So let's kind of move forward. We'll do some, how do you get it? How do you prescribe it? We'll summarize, and hopefully there's a lot of good questions out there for us, or if anybody has any CeQur stories or patient examples you want to mention, please do so. You want to prescribe CeQur Simplicity, the 4-day, it's an 8-pack. So it's the 4 days, so it's an 8-pack. It comes with the 8 patches, a guide. It's a beautiful guide that very easy to follow. So I usually actually show them that guide to go through with them. You also want to prescribe the inserter. So where the patch is not reusable, so you throw it out in 4 days, the inserter you're going to save, you put that patch in there. It's very easy to train patients. I haven't had a problem. They keep that inserter, fill the patch, and don't throw that away. So don't forget to tell them. Although it is available, you can always get another one, but remind them, don't throw that away. Don't forget to prescribe a vial of rapid acting insulin, so approved for Humalog U100 or Novolog U100. And in that package is going to come with what you need to fill that patch. So you just need that vial. You don't need to prescribe needles. Have the patient call CeQur Cares if they have any problems. I know for myself, my rep, Dave Barry, will make a personal visit to help a patient if he needs to. So reach out to your reps, and they will help you figure out, and Chris will come in and tell you a little bit more about CeQur Cares and availability of other people to do training with them. And I have not had any problem getting this covered on commercial or Medicare. If it's covered, which should be for most do have a copay of less than $50. And there is a savings program for people who have a high copay in their commercial insurance. So you can get that savings card at myceqursimplicity.com/savings. So who is a candidate for CeQur? I want you to remove that insulin pump out of your heads. This is, so when we're thinking about, well, I wish it did this or this or this, this is instead of an insulin pen or instead of syringes. So this is that patient that's struggling to have to inject. They have diabetes distress. They don't want to use the needles. They want to have something that's easier, that's discreet, less embarrassment, that's instant, that's there for 4 days. So that's your patient. If someone's missing mealtime insulin, David, is that you?
Yeah, for my practice, I actually prescribe it even for those who don't struggle. Like if they're doing well with their pens, I offer it as a simplified version of what they're currently doing to free them from those 12,000 steps in a year to do something else.
Yes. So what I do actually is when I'm going to intensify someone to mealtime insulin, I show them, here's your options. We could do this, and I show them the CeQur, which when we come back on camera full screen, you can show everyone. We could do this, or you're already using the basal insulin. I can give you that rapid acting insulin, and you'll do the same thing 3 times a day. Which one do you think you would prefer? The other thing is, my rep Dave always makes sure that I have starter packs. So talk to your reps about getting some starter packs. And I'll actually, if the patients, sometimes they might just say, well, what do you think? And I'll say, well, what, you already know how to use the pen. Why don't you try this? And then you tell me what you want to do. So nobody's going to say, I'd rather inject and go through 12 steps and do all this. At least not in my experience. So now that we have that option, I'm always going to offer that option and let them choose, because patients are also more adherent to things they choose that they want to do. So, and we know insulin adherence reduces, all-cause cost. We also know insulin adherence improves outcomes. So we want all of that. So I do truly believe that CeQur addresses the barriers to mealtime insulin dosing. And we know from that data it's preferred for by patients and by providers. So CeQur Cares and NipRx, and Chris can correct me if I can say it differently. I think that's the national pharmacy, specialty pharmacy, but your local reps can also explain to you where to get it or how to get it, but you can also write a prescription and send it to a patient's preferred pharmacy. So this material is intended for healthcare professionals, and you can please look at the website and the product information, which I'm sure Curtis has put into the chat for you. And with that, I'm going to thank you and stop sharing so we can make some eye contact directly and have David, unless you have something burning, Chris, that you need to say, we'll have David just do a little show and tell.
So this is there. This is how it is. And then you have to press the 2 buttons to click it. So that's 2 units. So most of my patients will be in a 2 to 4 unit mealtime dose to start. So that's like 1, 2, and they're done. They can start eating.
Excellent.
I'm going to test the expert here, David. So what happens when the patch is out of insulin?
It stops clicking.
So some safety features. So those buttons will lock, ladies and gentlemen in the audience. So those buttons will lock, and that tells the patient it is out of insulin. So that's a safety feature there. And then it's we can't pick up the audio now, but each time David was squeezing the buttons, there's a tactile, and you can hear it as well, so the patient knows that it's dosing them with their mealtime insulin. So I'm going to, we have plenty of time for Q&A. Jennifer and David, thank you so much for the fantastic presentation. And I'm going to call out my colleague Terry in Arizona. We're waiting for a question from those folks there. And we do see one question came in right now. How much insulin used for priming? So I can take that question, and so a reminder again, the maximum is 200 units. The patch also requires a minimum fill of 100 units. And to answer your question, for that audience member, who was that? That was Michael C. Thank you for your question. So 20 units of insulin are required to prep and prime each patch. So that leaves 180 units of usable insulin. So thank you for that question. So I'm going to encourage everyone to feel free to ask more questions. I do have some very frequently asked questions that we can discuss. And let's see here. So who can use CeQur Simplicity? So for that question, we are labeled for the use in adults over the age of 21 who have been diagnosed with type 1 or type 2. And why that is, because those are the folks that were included in our clinical trials. And Terry from Arizona, she did ask a question, are there any insurances that are not covering it? And that's probably an appropriate question for me, Jennifer and David. So we do have a great coverage. So what I can say, and I believe it was in our one of our summary slides there, but we do have great coverage with commercial plans. So most patients have a copay of about $50 or less when covered. And individual plans will vary, obviously. And with Medicare, we also have good coverage. And it also gives me a good opportunity to reiterate that our copay savings card, I did in the chat box put the link for the copay savings card. So I encourage you all to click on that link and have that readily available for you to reference.
I do have people, when I'm talking about CeQur, giving a talk or whatever, ask about pregnancy. So it does come up. So, we might as well talk about that a little bit. So remembering it's indicated for type 1 and type 2 diabetes. So not specifically studied in someone who's pregnant, but pregnant people get gestational diabetes, they get type 1 diabetes, type 2 diabetes. And we know that insulin is required, and we need tighter control. So this is a delivery device. So it's the insulins that are approved for use in CeQur are approved in pregnancy. And so really it's a clinical judgment question for you, in my opinion, that if you have somebody, and we know people miss insulin doses, and when they're pregnant, we need to have tighter control, and it's really critical to have that insulin. It would be a clinical judgment. And ask the patient, here's your choices. What do you think would be best for you?
And because the classification of CeQur is very unique, it does not limit the approval of other delivery. So I have patients who are both on the pen. I prescribe them the pen, I prescribe them the patch, and whichever they're more, feeling like using for the day, they can use that. So on times that they don't want to use the patch because they're going somewhere where the patch isn't appropriate, they can use their pens for that day, and the insurance pays for both the patch and the pens too.
And they can wear it, on their arm. They don't have to wear it on their belly, right, Chris?
Yeah, see, all some great tips that we're getting here from Jennifer and David. So any subcutaneous area is okay for CeQur Simplicity. Just remind your patients that they have to have the dexterity to reach, right, and squeeze those two buttons. Majority of our patients do wear it on the abdomen, but arm is fair game. So again, any subcutaneous area is fine. We do have one more question coming from our watch party in Arizona, and that's what happens if patient does not change their patch after 4 days? So Of course, just to reiterate, anything after 4 days would be off-label, but I can say that for us to get the 4-day wear clearance from the FDA, it was studied for safety for up to 6 days. So again, that would be under your clinical judgment. After more than 4 days would be off-label, but I can state that to get that 4-day wear clearance, we were studied for safety for up to 6 days.
Michael C's on fire. Hi, Michael. How are you? So what happens if patients use insulin, a higher dose of insulin so that the patch doesn't last 4 days and it lasts 3 days? Well, you would have to write for more patches, right? Or it would be a shorter day supply. So in the pharmacy end, that you'd have to write in the SIG in the directions how many days that box is going to last so that they can refill it sooner, because you can only get an 8-pack, right? So depending on their pharmacy benefit, and correct me if I'm wrong, Chris, if they would need, let's say, 10 or 12, you could give them a box of 16. Nobody's going to break a box up on the pharmacy level. So, but they would just change the day supply, perhaps.
Yes.
Thank God we have a pharmacist on tonight's webinar. And let me see any other. I know Curtis is addressing questions as well. Again, with the 4-day wear question, Curtis provided.
Terry has a good one. Are you coming out with a sticker for heavy sweaters? And that's a good sweaters, meaning sweating sweaters. So there are some covers that you can use, certainly. And I think that, is it on the website what covers you use? I mean, I also, if I haven't had any heavy sweaters, but I will tell you for CGM, and David, please weigh in if you have another tip, is you can get literally a bottle of skin tack. It will outlive the patient. It's like $12. It's above 4 ounces and it has a little fluffy ball in there. And when you unscrew it and just put a little bit of skin tack on, that tacky stuff, it will outlive the patient. That's how long this will last.
I ordered the individually packed. I didn't know there was a bottle.
Yes, yes, a bottle.
It makes it essentially waterproof wherever you apply that.
Yeah, and sticky.
Yeah.
So I'd probably start with that, but or the cover, whichever patients prefer.
So I'm not surprised that question came from Arizona. Obviously, in the
Oh,
summer months there, it's hot. But in our website, we do have recommendations. So patients can augment adhesion by using medical grade adhesive bandages or tapes. An example of those are hype tape or micropore surgical tape over the patch's adhesion. Also, these are great opportunities to call our CeQur Cares team. So I'll take advantage right now to give them a shout out. So CeQur Cares is our staff of nurses on staff. I did put the link to their contact information, to make sure to please utilize that link and save it. But we have our CeQur Cares staff available to help you with that initial training of a patient, or if you, the provider in your own office, can do that initial training. But what happens 4 days later, when that patient's at home, they can call into CeQur Cares, and CeQur Cares can help them with that second to third patch change. And as Jennifer, I believe, discussed in the presentation, typically we see about the study showed 30 minutes for training for a patient to feel confident. But we see anywhere from 15 to 30 minutes and about 1 to 3 patch changes for them to really feel confident moving forward.
Yeah, and David mentioned that he sometimes prescribes a pen, a rapid acting pen, that some patients may or may not need that. So that kind of comes up with, if somebody has a scheduled MRI or they go in for an MRI, you can't use the patch. So if there's something happening, there's no reason why patients can't temporarily use their insulin pen or use an insulin pen. Remember, most of these patients are going to be on basal insulin. They already know how to use an insulin pen. So it's not a big deal if they say, hey, this is happening to me, or I'm going through this and can I stop? Well, of course. Of course you can.
Yeah, I'm glad you mentioned MRI, Jen. That's one of our common questions that we do have. So the patch contains metal parts, so it should be removed prior to any imaging exam. And thank you, Pamela Rosario. Great webinar. I appreciate the feedback. Maybe we'll do one more question. And we've already covered training.
What about just a reminder on the dosing that it is 2-unit increments. So if you do happen to have somebody with type 1 diabetes that is so highly sensitive and they need those 1 unit or half units, it's not for that particular patient. So, most people, type 2 diabetes, 2-unit increments is totally appropriate. And even type 1, 2-unit increments for most are totally appropriate, but no half doses, just 2 units.
That's a fantastic reminder.
Mhm.
And why don't we do one more question? Another common question we get is, and we talked about this, is as a reminder, so the patch cannot be refilled or reused. It is designed for 4 days. So it cannot be reused due to an increased risk of infection, malfunctions, or incorrect insulin delivery. So just a reminder again, it's not possible to refill an empty insulin reservoir in the patch. So with that, I think we'll start to say our goodbyes, and want to thank you all for attending tonight. Thank you all those that